Yeah. So good evening, everybody. I'll introduce Dr. S. Gayatri, Associate Professor, SWIMS Tirupati, to wrap it to today's case discussion. Thank you.
Thank you so much, sir. Good evening, everyone. It is my proud privilege to have this opportunity to introduce the distinguished joined today. So we have our state expert today, Dr. Alok Sachin sir, who's professor in HOD and the Dean of SWIMS Tirupati. Thank you for joining us, sir, today. And for national expert, we have Dr. Sachin Mittal, sir. Sir is consultant endocrinologist at Fortis Mohali. So thank you so much, sir, for joining us today. In addition, as the guest of honor, it is our proud privilege to have Dr. Kotwal sir. So Dr. Kotwal sir does not need any introduction. He was the past president of Endocrine Society of India and now is the current president of Indian Thyroid Society. And today that we have a talk on thyroid eye disease, we are very fortunate to have him today with us. Sir, welcome to our webinar today. Thank you for being with us.
Thank you.
We would want your pearls of wisdom today before we go ahead with our talk.
Thank you. So, should I say something?
Yes, sir. Please do, sir.
Yeah. Dear esteemed colleagues and my dear young endocrinologists, I'm always fond of my young people. It is really privileged to be amongst such a vibrant gathering of endocrine minds today. Graves' disease, one of the oldest autoimmune disorder, continues to offer new lessons not only in thyroid physiology but also in the orchestration of immunity, stress, and emotion. Now, changing face of Graves' disease. Once considered a purely thyroid-centric disease, we know that this is a systemic autoimmune disorders, autoimmune symphony, and various triggers like environment, endocrine disruptors, and even gut microbial diversity. All these lead to onset or relapse of Graves' disease. These are some newer concepts, and we have to now broaden our gaze from thyrotoxicosis to neuroimmunoendocrine turbulence. And we know that a lot of peptides are in the pipelines to target TSH receptors also. Some of the innovative clinical pearls, just for my younger colleagues, now there's a personalized anti-thyroid therapy based upon the TSH receptor antibodies, TSH receptor epitomes, how it changes, then microbiome modulation to alter autoimmunity, then very importantly, mind-body axis to alter sympathetic activity to target autoimmune processes, and not to forget endocrine disruptor vigilance. We know plastics, polythenes, cosmetics, all these include traps, and detoxification of the in endocrine practice is a new therapies now these days. Now, future is something restoring immune harmony, not merely achieving euthyroidism, but integrating artificial intelligence and setting pattern recognition in ultrasonography and antibody trends. My dear friends, as endocrinologists, we are not merely hormone healers, but we are architects of balance, bridging molecule and mindfulness. Let today each session ignite new thinking, compassion science, and collective purpose. Thank you and Jai Hind.
Thank you so much, sir. We hope we reach your expectations, and we hope that this actually ignites the right thoughts in everyone who has joined us today. So with your guidance today, we would like to start off our webinar. So today as a presenter, we have Dr. Soumya Perumalla, the second year senior resident from SWIMS Tirupati. Soumya, kindly present the two cases of thyroid associated orbitopathy which you have. Over to Dr. Soumya.
Can you call her, please?
Dr. Gayatri, I think she left the meeting. I don't know whether it was accident or net connection.
Yes, sir. She somehow got logged out, it seems, sir. She's joining in again. Yes, sir.
Right.
Yes, sir.
Okay, so let me
Yes, sir.
tell something about these two cases. These were cases in which I was personally involved, at least in the first case. The second case I have seen only as a visiting consultant. You have seen more about him. So the first case was a gentleman whom I followed after onset of thyrotoxicosis. That was almost like 6 or 7 months after onset of thyrotoxicosis. This guy was a policeman who was who came to SIMS for symptoms of eye disease. His onset of thyrotoxicosis, he was managed outside, and after sometime after 6 months or so, he had developed prominence of the eyes. That was the time when this gentleman was sent to SIMS. So when he came to us, he was already on carbimazole. And after evaluating his eye disease, we started further treatment for his eye problem. So this gentleman his initial thyrotoxicosis was there. I think that the T3 and free T4 were high, TSH was low, but the goiter was not very prominent. So that is how we saw him at that time. Eyes were prominent, but it was not means that what I remember is his total proptosis was maybe 23 or 24 millimeter bilaterally. It was not great. It was not grossly obvious. But clinical activity we score used to be around 3 or 7 for both the eyes. So we admitted him and we did the evaluation. And after the evaluation, we started him on antithyroid. He was already on antithyroid drugs. We started him on medication for systemic steroids for management of thyroid-associated ophthalmopathy. So after starting the management for thyroid-associated ophthalmopathy, slowly his prominence of eyes and clinical symptoms came down. Prominence of eyes a little bit only, but clinical symptoms changed a lot. So when that happened, we completed the first course of treatment, stopped treatment, and then he was in kind of remission. Thyrotoxicosis had also settled down, and thyroid-associated ophthalmopathy had also settled down. So at that time, he was managed clinically for thyrotoxicosis, and we had stopped. And we stopped his methylprednisolone was stopped. And for thyrotoxicosis, I think he was on a lower dose of carbimazole. I think Dr. Soumya has entered. Dr. Soumya, are you there?
Still showing as joining, sir. I'm trying, sir.
Yeah. Okay. So in between, we thought he has gone into, at least thyroid-associated ophthalmopathy has gone into remission. And then we managed his thyrotoxicosis. In between, he was not very regular. That is what happens to most of the patients with the thyroid-associated ophthalmopathy. When it clears, at least when it goes into remission, they think that the problem is over, and they either stop treatment or stop visiting the doctor. Most of them don't realize that thyroid-associated ophthalmopathy can be troublesome. So then he was also on and off. He was not visiting us very regularly. Ramohan, is she?
Yeah.
Dr. Soumya is.
Sir,
You
sir,
can
I am logged in, sir.
yeah.
Right. Yeah. Start.
Just a second, sir.
So Dr. Soumya is here, so now she will take us through the presentation.
Just a second, sir. I'm not able to share the screen in the phone, sir.
You're logging in from phone?
No, sir. In laptop, I'm not able to log in.
Again, you send a request from laptop.
Okay,
please.
sir. Okay, sir. Thank
So stay in phone. Yeah.
Okay, so while Dr. Soumya is trying to log in, let me regale you with my messed up memory about this patient. So in between, he was off treatment for thyroid-associated ophthalmopathy, off and on coming, not very regular. And then the thyroid-associated ophthalmopathy again started worsening. His clinical activity score again started worsening. He developed redness and conjunctival edema. And that time we again had to start him on treatment for systemic steroids. And this time we continued the treatment, and I think we suggested him to go for thyroidectomy. He was not very comfortable. He was not very, he did not accept the idea of thyroidectomy in the beginning. So he was delaying it. But finally, after completion of the second course, the remission, the total improvement in vision was there, but his eye signs did not completely normalize. The redness and swelling was still around. So finally, he got convinced and he went for thyroidectomy. And after the thyroidectomy, the change was dramatic for his thyroid-associated ophthalmopathy, which even after 2 courses of methylprednisolone had not completely settled down. So he at no point did he ever have dysthyroid optic neuropathy or worsening of vision. I think Dr. Soumya is able to share now.
you. Yes, sir. Good evening, everybody. Respected professors, thank you for providing this opportunity to me. I would like to present interesting cases of thyroid-associated orbitopathy. Case number 1, a 65-year-old male patient presented to the Department of Endocrinology SWIMS in May 2022 with the chief complaint of redness of both eyes from the past 6 months and complaints of excess tearing from both eyes from the past 6 months. History of present illness. Patient had complaints of redness and excess tearing from both the eyes from the past 6 months, which increased in severity over the past 2 months. Patient had complaints of protrusion of both eyes from 6 months, which was not associated with pain, associated with blurring of vision. Patient had complaints of decrease in far vision, no history of any double vision, no history of difficulty in perceiving colors. History of tremulousness of limbs was present. No complaints of palpitations. Complaints of increased frequency of passage of stools was present. No complaints of excessive sweating was present. No history suggestive of proximal muscle weakness. No complaints of shortness of breath. No history of swelling of lower limbs. No history of recent loss of weight. No history of any skin changes. No history of swelling in the front of neck. Treatment history. Patient was diagnosed to have hyperthyroidism 8 months back at an outside hospital, and patient was started on carbimazole since then. The initial symptoms at the time of presentation were weight loss, tremors, and palpitations. Patient had developed visual complaints 2 months after he was diagnosed to be hyperthyroid. At presentation to SWIMS, he was on carbimazole 25 mg per day. History of past illness. No history of any significant illnesses in the past. No history of any similar illness in the family. Personal history, appetite is normal, sleep is normal, and hyperdefecation present. Bladder habits are normal. Patient is a smoker since 50 years, and patient has stopped smoking 8 months back when he was diagnosed to be hyperthyroid. Patient doesn't consume alcohol. Summary, a 65-year-old male patient who is a known case of hyperthyroidism, diagnosed 8 months back, presented with visual complaints like redness and watering from both the eyes since 6 months, which increased in severity from the past 2 months. It was associated with blurring of vision and decreased far vision. It was not associated with pain, double vision, or abnormal color perception. Patient had thyrotoxic symptoms like excessive sweating, tremors, and hyperdefecation. No history of any neck swelling or fever. At presentation, patient was on carbimazole 25 mg per day. With this history, I would like to consider thyroid-associated orbitopathy as a prime differential diagnosis. In the background of hyperthyroidism and bilateral involvement and not associated with any pain and over a gradual period of time. And other differentials would be orbital myositis. which is usually a painful condition, which can be unilateral to start with and can be sequentially involving the other eye, and which is usually of acute onset. And other differentials include orbital pseudotumor, which is a painless and unilateral condition, and orbital cellulitis, which is painful and usually unilateral, more commonly seen in children. General examination, patient is conscious, coherent, and oriented. Patient BMI is 29.4 kg per meter square. No pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Clubbing of all the fingers were present. Skin, hair, and nails were normal. Patient had fine tremors of both the hands. Pulse was 84 per minute, regular, normal volume, normal rhythm. All the peripheral pulses are equally felt. Blood pressure is 120 by 80 millimeters of mercury in right arm sitting position. Respiratory rate is 16 per minute, abdominal thoracic. Temperature is 98.4 degree Fahrenheit, and JVP was normal. Ocular examination. The clinical activity scoring was done, which was 3 by 7 in both the eyes, with the presence of eyelid edema, conjunctival redness, and chemosis. And visual acuity was 6 by 6 in the right eye and 6 by 9 in the left eye. Fundus examination was normal. In both eye, proptosis was present, which was about 22 millimeters in both eyes. Cornea was clear. Both the eyes were, pupil was normal in size and reacting to light. No relative afferent pupillary defect was present. Intraocular pressure in the right eye was 10.3 millimeters of mercury, and in left eye it was 11.7 millimeters of mercury. Extraocular movements were full. Examination of thyroid gland. On inspection, no obvious goiter was visible and no dilated veins over the chest wall, no scars, sinuses, or facial plethora. Pemberton sign was negative, no visible pulsations. On palpation, no palpable swelling in the region of thyroid gland, no palpable thrill. Retrosternal percussion was resonant, no bruit was heard over the region of thyroid gland. Other system examination, cardiovascular system, apex beat is normal, S1, S2 are normal, no murmurs, and JVP was normal. Respiratory system, normal vesicular breath sounds were heard and no added sounds. Abdomen was soft and no abnormality was detected. CNS and higher mental functions were normal. Cranial nerve examination was normal. Sensory motor and cerebellum was normal. Gait was normal. Skull and spine examination was normal. Diagnosis, a 65-year-old male patient who is overweight, probably having thyroid-associated orbitopathy, most probable etiology being Graves' disease, and with clinically active orbitopathy of 3 by 7 in both the eyes, with no optic nerve involvement, no goiter, thyroid acropathy was present, no skin changes, and risk factor being smoking. Patient was a smoker from the past 50 years. At the time of presentation to SWIMS, patient had a total T4 of 49 nanogram per ml, and total T3 was 0.8 nanogram per ml, and TSH was 0.003 milli international units per ml. Patient was on carbimazole 25 mg per day. As the patient had a clinical activity score of 3 by 7 with active orbitopathy, patient was considered for methylprednisolone pulse therapy. 500 milligram IV weekly was given for 6 weeks. At the initial period, a patient had a clinical activity score of 3 by 7, which got down to 2 by 7 by the end of 6th dose. And patient was also started on block replace regimen. Levothyroxine 88 microgram was added. And at the end of the 6th dose, patient had a total T4 of 92 nanogram per ml and total T3 of 0.8 nanogram per ml. With good response, patient was continued the remaining doses of methylprednisolone, 250 milligram every week for another 6 weeks. And by the end of July, patient has completed the course, and the clinical activity score came down to 1 by 7 in both the eyes. And 3 months later, patient was again reassessed and clinical activity score came to 0 by 7 in both the eyes. Ultrasound of thyroid was done, which was showing a normal sized thyroid with thyroid's 4 nodule present in the right lobe of thyroid. 2 more nodules were detected in isthmus of the thyroid gland and the left lobe of the thyroid. Patient was at this point referred for thyroidectomy, but patient had poor follow-up and did not go to the surgical department. Patient presented again 2 months later, and in January 2023, last dose of methylprednisolone was given in July 2022. And T4 at that time was 125 nanogram per ml, T3 was 0.9 nanogram per ml, TSH was 0.005 milli-international units per ml. Patient was on carbimazole 20 mg and levothyroxine 150 microgram. Clinical activity score again increased to 2/7 in both the eyes with conjunctival edema and redness. A patient was again lost to follow-up and later presented in May 2023 with the clinical with retroorbital pain. And patient at this point had a clinical activity score of 4/7 in both the eyes. And patient had spontaneous orbital pain, eyelid erythema and eyelid edema, and conjunctival redness in both the eyes. Visual acuity was 6/12 in right eye and 6/9 in left eye. Fundus examination was normal. As the patient had clinically active disease, patient was considered for second course of injection methylprednisolone, and patient was also started on tablet mycophenolate mofetil, 500 milligram BD for 24 weeks. And patient was planned for thyroidectomy after the active disease got settled down. After the second course of methylprednisolone of 12 weeks, patient clinical activity score got down to 2/7 at the end of 12th week in both the eyes. These are the thyroid profile values. Patient was the doses of carbimazole and levothyroxine were gradually adjusted, and by January 2024, patient was euthyroid, and the TSH receptor antibody level was 1 international units per liter. Patient was then referred for thyroidectomy. Patient has undergone total thyroidectomy in February 2024. HP examination was suggestive of Graves' disease. 1 month post-surgery, patient had a clinical activity score of 1/7 in both the eyes. And 3 months post-surgery, the clinical activity score got down to 0/7. And the patient has latest review in June 2025, where the clinical activity score was 1/7 in both eyes, with conjunctival redness being present in both the eyes. And patient was on tablet thyroxine 125 microgram. And latest T4 was 90 nanogram per ml, and TSH was 2.7 milli-international units per liter. Shall I proceed to second case, ma'am?
Yes, Soumya, was the patient euthyroid throughout?
Yes, the patient initially at presentation, patient was hypothyroid at initial presentation, sir. Later, patient was euthyroid throughout, sir.
Later patient was euthyroid.
Yes, sir. Patient was started on block
Throughout the
replacement. Post that patient was euthyroid, sir.
Okay, right. Right. So anyway, the response to methylprednisolone both the times was good. And mycophenolate, when we started mycophenolate, did we complete the 6 months course of mycophenolate?
Yes, sir. Patient has completed 24 weeks, sir.
So after completion of 24 weeks, was there further settling down of eye disease?
Yes,
Did
sir.
it come down further?
Yes, a clinical activity score, it was only 1/7, sir. Throughout, it was maintained.
At the end. Right, right. So what was there, apart from thyroid eye disease, was there any other indication for sending for thyroidectomy?
Patient had nodules also in the neck, sir. Scintigraphy was not done, sir. Thyroid's 4 nodule, 1 nodule was there, sir.
Oh, okay. Right. Right.
So despite the goiter is not much and the T3, T4 values also not much elevated, but despite that 25 mg of carbimazole, I don't know what is the requirement for the carbimazole. And so the dose of carbimazole 25 mg. So,
Yes,
and
sir.
what is the reason for taking block and replacement regimen for this patient? And that is my question actually. And the T3, T4 levels are not so much elevated. And but despite that, patient was on outside treatment. Some 25 mg the carbimazole was put, but after that also I think TSS value didn't go up much.
Yes, sir.
I don't know what was the reason why it was started on thyroxine. I don't know what is the reason block and replacement regimen was started for this.
Initial T4 was 45, sir, when the patient presented to us.
Oh, when they presented for that, that's why that just added the thyroxine rather than decreasing the
Yes,
So
sir.
why scintigraphy was not done? Just why I was asking what is the reason? Because we can do, even though there is a thyroid ophthalmopathy, you can't give radiation therapy ablation, but we can do the diagnostic scintigraphy. I think no, why it was not done? I'm asking. It's okay. It's okay. Yeah. You can do. I think no, sir.
Can I
Sir.
can I ask a question?
Yes, sir.
Yes,
So,
sir.
what is the indication of surgery as per your? Was it the thyroid eye disease or was it the nodules? According to you, when you referred the patient, what was the primary indication? I understand the patient had both the conditions, but what was the primary etiology we were planning to target when we were sending the patient for surgery?
The primary indication was active orbitopathy, sir.
But the
Previous.
score you said at that point of time was 0/7 or something like that
Yes,
at
sir.
that time by the time. So the
Yes,
score
sir.
actually had the disease completely had become quiescent at that time
Yes,
because you'd given 4.5 gram twice over a span of 2 different pulses, and then you have given a 6 months course of mycophenolate mofetil, and the patient has responded to both, and the clinical activity score now has reduced pretty much.
yes, sir.
So the thyroid eye disease, it seems, with your immunosuppressive therapy, has immunomodulating therapy has become much better.
Yes, sir.
So
But
that's what I'm asking.
there, a post-radioiodine ablation, there might be chance for a worsening of eye disease. So, yeah.
Okay. So secondly, the usual rationale, I understand what Dr. Reddy, I think, was trying to ask. The usual rationale when you're trying to put a patient on block and replace therapy is that you want to give a higher dose of anti-thyroid drugs so that, you can have a better action in terms of, the disease modifying action rather than giving a smaller dose. So that is why you keep on giving a block and replace therapy. But in here, what has happened is your block and replace therapy, your doses of carbimazole has gone down very, very low, from 25 milligram gone to 2.5 milligram OD. That's what I can see. So it seems like the disease activity per se, I'm talking about the metabolic activity per se, also was not great
Yes,
based
sir.
on the metabolic parameters. So I mean, whether block and replace really served the purpose over here or really tried to achieve the purpose on which it was intended, that again is a question. I mean, Dr. Alok sir and Dr. Ram Mohan can add and contribute.
Yeah, I don't remember this. I remember this case vaguely. I think
Right,
that the
sir.
first time when we referred the patient was because of the nodules, thyroid nodules. But second time after the patient had had a relapse, then I'm not very sure. Soumya will be able to tell it better. But I think that the patient was not going into remission. It was not settling down. The course had been, the treatment had been for more than 2 years, and the patient was not completely going into remission. And then she
Right,
had,
sir.
sorry, not she, he had a relapse of thyroid-associated ophthalmopathy. So at that point, we decided that the treatment, so the second time the indication was probably that the patient was not going into remission, and thyroid-associated ophthalmopathy, already one relapse had happened. So that is what I vaguely remember. I'm not sure. Maybe patient had gone into remission and we still pushed him for thyroidectomy. I don't remember clearly. Soumya will be able to tell better. Was the patient complete? Did the patient go into complete remission, Soumya?
No, sir. In the TSH levels, again, it was suppressed, sir. The patient was sent to thyroidectomy in February 2024, sir. Prior to that, again, TSH levels were not normalized, sir. It was again suppressed. 0.01 it has become.
And how much thyroxine were we given at that time? We had
Again,
stopped, huh?
we have stopped thyroxine and carbimazole 2.5 mg we have added, sir.
Oh, right. Thyroxine we had stopped. Okay. So how do we decide that the patient has gone into remission?
The TSH receptor antibody titers will go down, sir, and
Right.
patient can have decrease in the size of the goiter and with normalization of the TSH, sir.
Right. So here the goiter here was normal size. TSH receptor antibody, I think we did it only at the end of the treatment. We did not do it in the very beginning.
Yes, sir.
Right,
So
sir.
these two things did not help.
Yes, sir.
But TSH was the only thing which was not settling down.
Yes, sir.
That probably was the only thing.
Right.
I also don't remember it clearly that this happened some 3-4 years ago.
But you seem to have a fantastic memory, sir. You remember so many things of 3-4 years ago also. So it's an awesome memory you have.
This guy, in the beginning, he did not follow very frequently, but after the surgery, he seems to had a change of heart and he is following. So that's why I see him once in a while.
Right.
And he keeps on reminding me of all the mistakes I have made in his management. Fortunately, he did well. After surgery, he did well.
Yeah, because the response after surgery when the disease course has completely changed. So probably the stimulus there was pretty high. So I mean, I was surprised that the titer of antibody is only this much. You know, the kind of response which is there, probably it suggested of a more stimulus should have been there. But yes, we never know with these assays and all. But the response has been very good post surgery. So the end result has been good for him.
Yeah. Overall, it seems that in the end, it turned out well. So anyone else would like to ask any question? Dr. Gayatri, will you take up?
One more point I can tell is that most of this family history, if you take, they'll have definitely some autoimmune disease in the family history. They'll have like allergic rhinitis, asthma, vitiligo. This is not related to orbitopathy. Just I'm telling the family history, there is nothing significant. But definitely, whenever they have some Graves' disease and all, definitely they'll have their children will be having allergic rhinitis or vitiligo or asthma, rheumatoid arthritis. Definitely, if you go into properly, definitely they'll have this. History, if you take, they'll be having the history. This one just to add on point for the P, something like that. Okay. Yeah. Just.
Yes, sir. Thank you. So, Soumya, this patient has this long history of smoking. That is obviously a contributory risk factor. You also mentioned about alcohol. Does alcohol contribute?
Alcohol, in excess alcohol consumption can generate more free radicals, ma'am. It can aggravate the Graves' orbitopathy. In moderate to severe disease, it can aggravate, ma'am. Excess consumption is there. In moderate alcohol consumption usually doesn't have any much effect on Graves' disease.
Yeah. Okay. And you also mentioned about some bruit. You mentioned about the bruit. You auscultated over the thyroid gland. Yeah. So for auscultatory findings, that was what you mentioned.
Yes,
Would you wish to mention about any other auscultatory findings anywhere else?
ma'am,
Do you wish to auscultate anywhere else?
this
in a case
Lehman's
of
scratch
Graves'
would be
orbital.
in left parasternal area in thyrotoxic patient. Lehman's scratch can be heard.
Okay. What is it basically? What is that scratch? What is the thing being scratched? What is it basically? What is creating that sound and means Lehman's scratch?
Because of hyperdynamic circulation.
Okay. Okay. So any other bruit anywhere else? Do you want to hear anything else? Do you want to put the stet on the eye?
Yes, ma'am. In eye also, in active orbitopathy, patient can a whistling sound can be heard, ma'am, when stethoscope is kept. It is called Reisman sign.
Yeah, that's nice. Thank you. Sure. You can go ahead.
Second case. A 50-year-old male patient presented to endocrinology department on 14th October 2025 with the chief complaints of swelling and protrusion of right eye since 10 months and redness of right eye since 10 months and decrease in vision in right eye since 2 months. History of present illness, the patient was apparently normal 10 months back. Complaint started with swelling and protrusion of right eye associated with redness and watering of eyes. Complaints of increase in severity of the swelling and protrusion of eyeball over the past 2 months associated with decrease in the vision in right eye since 2 months. A patient had double vision since 2 months. It is present on opening both the eyes, and it is inconstant only with downward gaze and improving with the closure of left eye. Complaints of occasional watering from left eye is present. No complaints of redness, swelling, or protrusion of left eye. No history of any eye pain or palpitations, no history of tremulousness of limbs or excessive sweating or hyperdefecation, no complaints of shortness of breath, no history of swelling of lower limbs, no history of loss of weight, no history of skin changes, no history of swelling in the front of neck, no history of fever, and no history suggestive of proximal muscle weakness. History of past illness. Patient is a known hypertensive from 5 years on telmisartan and cilindipine. Patient is a known case of seizure disorder which was diagnosed 5 years back. Used anti-epileptic medication for 2 years and later stopped treatment. And no history, no other comorbidities in the past. No history of similar illness in the family. Treatment history. Patient was diagnosed to have hyperthyroidism 3 months back, and he was started on carbimazole 10 mg twice a day and propranolol 40 mg OD since then. Prior to presentation, patient has taken 3 doses of IV methylprednisolone 500 mg once a week for 3 weeks, and patient has been on carboxymethylcellulose eye drops. Personal history: appetite is normal, sleep is normal, bowel and bladder habits are normal. Patient is smoker since 30 years and has quit smoking from the past 2 months, and patient doesn't consume alcohol. Summary: a 50-year-old gentleman presented with the complaints of swelling, protrusion, watering, and redness of right eyeball since 10 months, aggravated from the past 2 months. Decrease in vision in right eye from 2 months, associated with double vision. Complaints of watering from left eye, and no other significant visual complaints in left eye. No history of any thyrotoxic symptoms and neck swelling or fever. And patient was found to be hyperthyroid 3 months back and is currently on carbimazole 20 mg per day and propranolol 40 mg per day. Patient is a known smoker and who has stopped smoking since 2 months. With this history, the most probable differential diagnosis would be thyroid-associated orbitopathy with the background of hyperthyroidism and painless condition with gradual progression. And other differentials would be orbital pseudotumor. As a patient, history-wise, patient is having unilateral eye involvement. We should consider other conditions like orbital pseudotumor, lymphoma, cellulitis, or myositis. But as this is a painless condition, orbital pseudotumor and lymphoma would be more preferential when compared to cellulitis and myositis. General examination: patient is conscious, coherent, and oriented. BMI is 22.4 kg per meter square. No pallor, icterus, cyanosis, lymphadenopathy, or pedal edema. Clubbing of all the fingers present. Skin and hair are normal. Skin and nails are normal. Hair is fine. No tremors are present. Vital data: pulse is 98 per minute, regular, normal volume, normal rhythm. All the peripheral pulses are equally felt. Blood pressure 130 by 80 millimeters of mercury in right arm sitting position. Respiratory rate is 18 per minute, abdominothoracic. Temperature 98.4 degree Fahrenheit. JVP is normal. Ocular examination: the clinical activity score was 4 by 7 in right eye with presence of lid edema, conjunctival redness, and caruncle edema. In left eye, it was 2 by 7 with presence of conjunctival edema and caruncle edema. Extraocular movements: all the movements were restricted in right eye. Abduction and adduction were restricted in left eye. And both eye proptosis was present. In right eye, it was 29 millimeters and left eye 26 millimeters. Right eye, patient had conjunctival prolapse with excoriation inferiorly. Cornea was clear. Bilateral pupil was 3 millimeters reacting to light. No relative afferent pupillary defect. Fundus was normal. And visual acuity in right eye 6 by 12 with in left eye it was 6 by 9 with improving with glasses. And color vision was normal in both the eyes. Intraocular pressure in right eye was 90 millimeters of mercury. In left eye, it is 17 millimeters of mercury.
Yeah, are you sure about this 29 mm? Right eye proptosis 29 mm.
Yes, sir.
This is Hertel or the other one is smaller
It was
one?
measured with Lutz exophthalmometer, sir.
So it was with Ludwig.
Yes, sir.
Okay. Maybe we should cross check with Hertel. 29 is the highest I have ever seen in proptosis.
Okay.
Yeah, please go ahead.
Okay. This is a clinical picture where the patient is having right eye severe proptosis with conjunctival prolapse, and excoriation is also present in the conjunctival part. And right eye, the globe is shifted upwards. Examination of thyroid gland. On inspection, no visible goiter was seen. No dilated veins over the chest walls, squamous sinuses, or facial plethora. Pemberton sign was negative, no visible pulsations. Palpation, no palpable swelling was detected in the region of thyroid gland, no palpable thrill, and retrosternal percussion was resonant, no bruit was heard. Other system examination was normal, no obvious abnormality was detected. Provisional diagnosis, a 50-year-old male with thyroid-associated orbitopathy, probable etiology being Graves' disease, and patient had clinically active and moderate to severe orbitopathy in the right eye with the clinical activity score of 4/7, and inactive and mild orbitopathy in left eye with clinical activity score of 2/7, no optic nerve involvement, no goiter, thyroid acropathy was present, no skin changes, and risk factor smoking was present. The initial thyroid profile in August 2025, T3 was elevated with 2.32 microgram per deciliter. Free T4 was elevated, which was 1.78, and TSH was 0.005. And a patient was on carbimazole 20 mg when he presented to us. And thyroid profile at our institute was T4 was 89 nanogram per ml, and TSH was 0.7 milliinternation units per liter. And all other investigations were normal. The baseline LFT was done, which was within normal limits. HbA1c was 7.5. Patient was not a known diabetic. TSH receptor antibody was sent. Report is yet to come. In view of moderate to severe orbitopathy in the right eye, patient was subjected to MRI orbit in order to rule out optic nerve involvement. The sagittal view showing the enlargement of the superior rectus and inferior rectus muscle in the right eye, whereas in the left eye there is involvement of the inferior rectus muscle. There is mild crowding at the orbital apex in the right eye. The axial view showing the enlargement of the medial rectus and lateral rectus in the right eye, and medial rectus in the left eye. The coronal view showing the enlargement of superior rectus, inferior rectus, and medial rectus in the right eye, and mild enlargement of the inferior rectus in the left eye. As the patient had mild orbital crowding in the right eye, in view of impending dysthyroid optic neuropathy, patient was given a pulse dose of injection methylprednisolone 1 gram per day for 3 consecutive days. And post pulse dose of steroids, there was improvement in movements in the right eye, but clinical activity score remained the same. Post-injection methylprednisolone therapy, there was some amount of reduction in conjunctival prolapse, and movements of the eye were slightly improved. Patient is now planned for a cumulative dose not exceeding 8 gram of methylprednisolone. In view of moderate to severe eye disease, patient was also started on mycophenolate mofetil 500 mg BD, and a patient was started on block replace regimen with tablet thyroxine 25 microgram added, and other local ocular supportive measures were taken, and the cessation of smoking was reinforced, and patient was started on oral anti-diabetic medication and discharged.
So Soumya, this HbA1c only now revealed that this person has diabetes. This
Yes, ma'am.
patient is not previously known diabetic. Okay.
Yes, ma'am.
So when you started an oral anti-diabetic medication, did you take any particular precaution to ensure that some medication is not used, not preferred or used? What is it that you, what?
Pioglitazones
Mhm.
usually should be avoided, ma'am. It can aggravate orbitopathy.
Okay. So what else did you add other than, so what did you add? What was the medication that you
Patient was
added?
started on metformin and vildagliptin, ma'am.
Okay. What else did you add other than the methylprednisolone regimen and other than metformin and vildagliptin? Did you add anything else?
Mycophenolate was added, ma'am.
Okay. Other than that, did you add anything else? Did you get the lipid profile done? Because
Lipid
TRAB, we don't have TRAB. Do we have anything else which can be corrected? Like at this age, any person with diabetes needs to be started on at least a moderate intensity statin as per the diabetes treatment guidelines. So have you started this person on statin?
No, ma'am, not at started.
And what is the is there any benefit of adding statin in Graves orbitopathy?
Yes, ma'am. Total cholesterol and LDL cholesterol have been linked to worsening of Graves' orbitopathy, ma'am. Statin treatment has shown mild improvement in the orbitopathy.
Okay. So talking about the improvement in orbitopathy, for this patient, we have MRI images as well. So
Yes.
is there any is there any value that you see in MRI which helps us in quantitatively documenting the improvement in treatment which goes parallel to improvement in CA score?
This extraocular muscle width and thickness we can measure, ma'am.
Okay. And anything related to the signal intensity?
In T2 signal intensity, in active phase, patient will be having enhancement in the muscles, ma'am.
Yeah.
As the patient becomes inactive, the enhancement decreases.
Yeah, so that signal intensity ratio, when you compare the signal intensity of the extraocular muscle to a temporalis muscle, that is one way in which you can calculate that ratio. And the fall in this ratio is usually proportionate to the. This actually helps pick up inflammation better than CAS is what is described. And then this also, the response in this is also seen proportionate to the fall in CAS is what is described. Can you name any specific MRI sequence which helps in picking up Graves' orbitopathy in a better way, which shows extraocular movement, muscle involvement in a better way? Any
Stir
specific
sequence?
sequence which has been described? Have you heard of TIRM sequence?
No.
It's a variant of STIR. Okay, it's a variant of STIR. It helps in picking up extraocular movement involvement. Intramuscular edema is something which is picked up better in this sequence.
Okay.
Any other differential you had you had mentioned about pseudo, you've mentioned lymphoma, you mentioned about myositis. Any other differential? How does IgG4 associated orbitopathy present?
In IgG4, usually patient will be having gradual onset only, ma'am. Bilateral involvement can be there, ma'am. It is also a painless condition, ma'am. But other multi-system involvement will be there, ma'am. And predominantly lacrimal gland involvement can be there, ma'am, which we can differentiate.
Okay. And the one thing which you very nicely had documented in both the cases is you mentioned intraocular pressure. In the first case, intraocular pressure was around 11. The second case, you mentioned almost 19.
Yes, ma'am.
So, was this 19 related to the bad clinical picture that was seen, or what is the effect of what IOP changes do you expect in Graves' orbitopathy?
Usually because episcleral venous congestion can be there, ma'am.
Okay.
Secondary to that, intraocular pressure can be elevated, ma'am. Usually inferior rectus can be involved, ma'am. On upward gaze, IOP rises in Graves' disease, ma'am. If it is the initial muscle to be involved, ma'am. Otherwise, in moderate to severe orbitopathy, intraocular pressure on whole can also increase, ma'am.
Due to the muscle compression, and after that, those mucopolysaccharide deposition also that might also impair their drainage.
Yes.
Yeah, sure. Sir, would you like to add anything?
No, I think you've already asked a lot of things. So a lot of learnings she has had already. Just a question. Do you start block and replace in all patients of Graves or all patients of Graves orbitopathy? How is the protocol like?
In Graves' orbitopathy, we are usually starting, say, block replace regimen.
And so what is the target in your mind? Like at that point of time, you're targeting certain dose of thyroxine or certain dose of, sorry, antithyroid drug to be given as a minimal, because that is a usual rationale when you're trying to do it. You want to give a higher dose of antithyroid drugs. So, and in case the patient gets into hypo, then you're actually trying to increase the dose of levothyroxine. That's the basic premise of using a block and replace, though not everybody uses it. Not everybody is a fan of it, but some people use it. There's nothing wrong in it or nothing right in it. Just an individual preference. So just wanted to know how the protocol is.
In orbitopathy patients, we are usually starting, sir. In order to avoid this changes in the thyroid, also we are using.
Yeah, so that's the reason why I'm asking, because the dose is only 20 milligrams.
Yes,
and you're using 25 milligrams of levothyroxine. If you want to give a proper block and replace, you may as well jack up the dose of carbimazole and give a slightly higher dose of levothyroxine. What is the harm in doing it? I mean, I might be completely wrong. I'm just trying to ask you.
No, I think what you have asked, Dr. Sachin, is absolutely correct. That we can give a higher dose of antithyroid drug, and while we are giving thyroxine, so we can manage. But it is just a marriage of convenience. That when when we find that the dose of antithyroid drugs is working and T4 has started falling, then before the patient goes into hypothyroidism, we start adding thyroxine and maintain the same dose. But you are right, we can give a heavier dose of antithyroid drugs for these cases. It is possible, and that will probably be better also.
Right. Thank you, sir.
One clinical question regarding the eye. Right eye in the primary case, it is a bit deviated, abducted actually. It is normally it is a restrictive myopathy. Actually, when there is an inferior rectus and normally it is a restrictive myopathy rather than paralytic. The whichever part is infiltrated, that eye, the eye will be deviated. But the right eye rather than inferior rectus, it is right eye in the primary case, it is deviated towards the, it is abducted actually. So more involvement of, but MRI image was showing not much showing involvement in the lateral rectus and all.
Yes, sir.
And you understood my question, ma? Actually, yeah, I understood that. Because it is a restrictive myopathy in Graves and all get, it is not like paralytic, like the eyeball is deviated towards the right side. That means that it is not medial rectus involvement. It is a lateral rectus involvement that is making the eye towards the right side. It is an infiltrative myopathy. It is restrictive myopathy rather than the paralytic one. That is the difference between the eye involvement from the other than the, like when you get the palsy, that is the difference. But the MRI images, whatever it is showing there, even there is not much involvement of the lateral rectus and all the images also MRI.
Yes.
I don't just my. Did you understand my question, ma?
Yes, this levator palpebrae superioris was also involved, sir.
LPS.
Yes,
Okay.
sir.
Sure. LPS is supplied by, okay, LPS is other than the LPS also is involved in the Graves. I don't know that. Just I'm asking. It is supplied by the, I think, superior division of the third now. I think so.
Yes.
And now I am telling, but the infiltration occurs in the LPS also, ma. Okay. LPS is not. It is only for the ptosis. No, it is not for the any extraocular movement. No LPS.
Yes, sir.
My question here is, in Graves will get IMSO, inferior rectus and medial rectus, like that it will be involved. But the inferior rectus when involved and medial rectus involved, the eye will be deviated more towards the convergent like that. But it is eye is abducted actually. In the primary case, when you have shown the picture, the eyeball is towards the right. I mean, to abducted it is actually. Yeah, that was my question actually. Okay. Look. Anything?
I also don't understand why it happened, but I think superior rectus was involved. Is it, Soumya?
Yes, superior rectus and levator palpebrae superioris both were involved.
Levator palpebrae superioris will be only for the lid. It won't matter for the globe. But when globe is going up, it should be superior rectus and inferior oblique, which should be there.
Yeah, superior rectus main primary action will be elevation. So that can be because of that, because of in elevation is the primary and accessory action, secondary action will be intorsion and adduction.
Yeah.
Superior rectus, elevation, intorsion and adduction. But why it is more towards that? It's okay. Yes, sir. Because of that only the eyeball is a bit upward tilted because of the superior rectus infiltration. Yeah. Yes.
It is upward tilted. Some lateral is there. That I also saw.
Yes, sir. Yes.
Yeah. I cannot explain that. Soumya, do you have any other explanation?
Probably due to superior rectus involvement.
Moreover, I think that the inferior palpebral conjunctiva part had prolapsed a little, which was making it even more prominent, sir. We initially thought that that 29 mm, we thought that there was some subluxation component, but it turned out that it was the palpebral prolapse. So that was also probably making it a little more.
Yeah, that is conjunctival edema and lid edema, which has made it so worse. So that is there, but still it is that upward gaze. The patient was in that eye was continuously in the upward gaze. So
Yes, sir.
so anything else, Soumya?
Guidelines of UGOGO guidelines. As per the 2021 European Graves orbitopathy guidelines, in case of mild Graves orbitopathy, a patient can be managed with local management like artificial tears when dry eye is present and ophthalmic gels. And in mild cases, in the areas of selenium deficiency, selenium supplementation at 100 microgram per day for a period of 6 months was found to be effective. And if the patient is having active disease with mild Graves orbitopathy, patient can be considered for immunomodulatory therapy. In moderate to severe Graves orbitopathy and active disease, the first line of treatment will be the IV steroids. Usually 500 milligram of intravenous methylprednisolone per week is given for a period of about 6 weeks. Along with that, mycophenolate mofetil sodium is given 360 milligram BD for 6 weeks. At the end of 6 weeks, response has to be assessed. If the patient is having good response or partial response, patient can be continued with the remaining doses of 250 milligram IV methylprednisolone for 6 weeks, and mycophenolate sodium can be continued for remaining 18 weeks, total of 24 weeks. And if the patient is not having good response, and no response at all, or with further deterioration at the end of 6th week, patient can be considered for second line treatment. And in those patients with the more severe involvement and active orbitopathy, there can be a consideration for higher dose of steroid at 750 milligram per week for 6 weeks, and the response has to be assessed in a similar way at the end of 6 weeks. If there is a good or partial response, patient can be continued with 0.5 gram of methylprednisolone for the remaining 6 weeks. And if there is no response or further deterioration at the end of 6 weeks, patient can be considered for second line treatment. The available second line treatments include a second course of IV methylprednisolone, which is usually started 4 weeks after the first course, or patient can be started on oral steroids along with immunomodulatory agents like cyclosporin and azathioprine. An orbital radiotherapy can be given along with oral or IV steroids. And other possible drugs include teprotumumab, which is an IGF-1 receptor antagonist, and rituximab, which is B-cell monoclonal antibody, and tocilizumab, which is interleukin-6 receptor antagonist. All of them have been found to be useful in second line treatment. Sight-threatening orbitopathy, whenever the optic nerve involvement is present, intravenous methylprednisolone at 1 gram per day can be given for 3 consecutive days, and daily monitoring of ophthalmic parameters should be done. At the end of week 1, patient has to be assessed. If there is an improvement, patient can be continued for IV methylprednisolone for another, as in the week 1, and if further response is good, patient can be continued with 0.5 gram of IV methylprednisolone per week with a cumulative dose of less than 8 gram. If at the end of 1 week, a patient has no response or further deterioration, patient can be considered for urgent orbital decompression surgery.
Thank you, Soumya. We have some other senior endocrinologists from all over Andhra Pradesh joining in. So, Obul Reddy sir, would you wish to comment anything?
Nothing, madam. Nothing. Nice presentation. Nothing, madam. I didn't have any.
Thank you, sir. Shailja madam, madam has also joined us. Shailja madam, if you'd like to. Actually, today I think Dilip sir and very senior endocrinologist Dilip sir and Padmalata madam also had joined, but they probably signed out by now. Shailja madam, do you wish to give any inputs? Sir, Sachin sir, do you wish to give any inputs, sir?
No, I think it's good, and Dr. Soumya has presented very well. And
Thank you.
so the two cases have been good. Thyroid orbitopathy, always something new to discuss and always something new to learn. It's an enigma. We always, somehow fall short of patients' expectations. And there are so many more things to learn in thyroid eye disease. We really look forward to an era where we are able to have those second line options, because many of those patients, once we exhaust those steroids and and mycophenolate, many of those options, actually we are looking forward to that, but we don't have hands on those options. So probably that was something be exciting thing to look at. Over a period of time, we have started using more and more of thyroid receptor antibody, TSH receptor antibodies in many of those patients. So what we have seen is the titers, when they have fallen really compared to earlier, those people usually tend to do better. And that's what makes sense also, even though that's not like, you cannot generalize it, because it's an expensive test. Not everybody can, not for every patient you can do that. But yes, um, so well presented, Dr. Soumya. Thank you.
Thank you, sir. Thank you so much. Kotwal sir also joined us, but it looks like sir has signed out. Alok sir, would you wish to give any inputs?
I think Dr. Satish is there. Dr. Satish from Anantapur. Would you like to add something, Dr. Satish? Dr. Shalja?
Yeah, good evening, sir. Yeah, the presentation was really good, Dr. Soumya.
Thank you, ma'am.
And two case presentations are really like when we were in DM period, we never tried mycophenolate, but it's good that we were using methylprednisolone only. But it's good to see this. It was way back, almost 10 years back, but that was really good presentation. I could know few good points from your two presentations.
Thank you, ma'am. We have some other senior endocrinologists from other states also who have joined, Sandhya ma'am, or any other endocrinologist who would like to, or any other PG who would like to raise any queries or would like to give your inputs. Ramohan sir, thank you so much for this opportunity. If you're not held up in the other ESI webinar that is happening simultaneously on another platform, would you like to share anything, sir? We are so very thankful to all of you who have joined us today online, because simultaneously on Facebook we have another ESI official webinar going on.
Yeah. We had a great discussion today. Thank you, Sachin sir.
I think, Dr. Ram Mohan, we should make a replica of you. One replica in this webinar, other replica in the other webinar.
Thank you so much, sir. Thanks for all the insights, sir. Thank you very much.
Thank you,
Yeah,
Dr.
Dr.
everyone.
Sachin, I think it
Thank
is
you, Alok
possible with
sir.
AI. It
Yes,
can be
sir.
done.
Yeah. Thank you, Alok sir. Thank you, Dr.
Thank you.
Gayatri, and thank you everyone. Good night.
Thank you,
Bye-bye.
sir.
Right.
Good
Bye.
night, sir.
Bye. Bye. Bye.
Bye-bye.